He graduated.
This meeting is being recorded.
Okay, sorry. So I heard the recording thing. He graduated from the University of Puerto Rico, or UPR, School of Medicine in 2014. He then went on to complete his PM&R residency at UPR, where he was chief resident from 2017 to 2018. He completed a primary care sports medicine fellowship at Mayo Clinic, Florida, and he currently is part of the PM&R department in sports medicine program at Mayo Clinic, Florida. His great academic and leadership performance made him a recipient of the Carlos Armstrong Rezzi's Leadership Award and the Rafael Barros Martinez Academic Excellence Award in 2018. He also received the Resident Teacher Award in 2018 for his dedication to teaching fellow residents and medical students. He has been invited to speak and teach at multiple workshops and conferences and has written multiple articles and book chapters in the field of PM&R and sports medicine. He has a special interest in breast cancer rehabilitation, which he's here to talk to us about tonight. Thank you, Dr. Rosario, so much for being here.
I really appreciate the invitation. Can you see the slides?
Yes.
All right, thank you. So yeah, I really appreciate the invitation to talk a little bit of my favorite topics, which is kind of cancer rehabilitation. So this is a presentation that I gave actually in APM&R, I think 1 or 2 years ago, that we kind of established like a session of giving providers tips of how to start seeing patients with cancer in their clinic, so you feel more comfortable in seeing those patients, because sometimes the diagnosis of cancer can be a little bit of scary and you would think that it is very complicated, but actually it's not. So we're going to run through my presentation, and hopefully at the end you feel that it might be something that you may want to explore in order to offer these PM&R services to patients with cancer. I don't have any financial relationships. So the objective, like I said, is basically discuss how a general physiatrist can provide the necessary services to help patients with a diagnosis of cancer by providing maybe some diagnostic tools, pharmacological medication, procedures to improve their quality of life. We're going to discuss the pearls and the precaution that we have to have with the cancer population. And also we're going to review how some of the skills that you learn in PM&R residency are going to be very helpful in patients with a diagnosis of cancer, like maybe musculoskeletal ultrasound and electromyography. So to put this in perspective, there's 70 million cancer survivors in the United States, a number expected to exceed to 22 millions in 2030. And the life expectancy of at least 5 years in the 1950s was less than 35%. In the 70s was 49%, and in 2020 was 70%. So patients with the diagnosis of cancer are surviving more their diagnosis due to the advantage of the treatment and the different diagnostic tools. However, it has been described that between 50 to 90% of those patients can develop one impairment that is affecting their quality of life that might require evaluation by PM&R in order to get them better. And to put this in perspective, when we think about PM&R, we always think that we can take care of kind of brain injury patients and spinal cord patients, which is very quickly, we came up with that thought. However, the amount of new injuries of spinal cord in the world is between 250 and 500,000 people. In cancer, the amount of people that are diagnosed with cancer is way higher than that. So we need to start thinking that cancer needs to be a priority in the rehabilitation field, because a lot of patients are developing these problems. So one of the big things that I have interest, because I'm a sports doctor, is why during my training, we were not seeing a lot of patients with cancer if everybody have cancer. And we did this study in my residency. This is my residency research that we published in 2021, that we kind of created like a survey to oncologists, because my hypothesis was that the oncologists and the providers seeing the patient with cancer do not have enough knowledge about the benefit of rehab, so they do not refer the patient for PM&R evaluation. So we found out that 88% of the oncologists have received minimal or zero education about cancer rehabilitation, its benefits and indication. 72% of oncologists were referring less than 15% of their patients, and we already saw that between 50 and 90% will benefit from my evaluation. Almost 1/3 of those subjects referred less than 5%, so barely they refer any patients for rehab. And the interesting part is that 92% think that rehabilitation is always or very important for their patient, but they still don't refer it. So what I've been doing for the last couple of years is try to kind of educate and try to emphasize the importance of cancer rehabilitation so we can kind of decrease that gap. And when I came here at Mayo, nobody really was tackling the cancer rehabilitation portion in the department. So I met with all the oncologists and the system. And the breast center was actually very interested. I've been working with them a lot, and that's how I became kind of a breast cancer kind of expert in terms of complications, because I'm seeing now like between 7 and 10 patients per week of breast cancer. So the first question that I always try to bring is, why do I see patients with cancer in my clinic? Like I said, I did a sports medicine fellowship. I see athletes in my clinic. I see musculoskeletal problem, but I feel that there's a big role of everybody that needs to incorporate some kind of cancer rehabilitation in their practice so we can help this patient. And like I said, the big issue is that patients with cancer are living longer, which is great, but then they're developing these kind of impairments that nobody's addressing, and it have created like a decreased quality of life and affecting their independence. And what I have found is that most oncologists, unfortunately, radiation oncologists and surgeons do not understand really the importance of rehabilitation. When patients tell me, when they complain about this kind of complication from their treatment, the provider or the physician tell the patient that this is going to be your new normal. It's great that you're surviving the cancer, and nothing to do in terms of this complication that you have developed. So rehabilitation is not commonly offered. The positive side of seeing patients with cancer is that actually they want to get better. And in PM&R, sometimes we see challenging patients that they don't follow instructions, they don't exercise, they don't want to really get better. There's some secondary gain. Actually, most patients with the diagnosis of cancer are fighting and they want to get better. So it's kind of very refreshing. Most of them are very appreciative and they follow recommendations. So the other question that I kind of bring up is like, do I need to do like a cancer rehabilitation fellowship to see patients with cancer? And to put this into perspective, the cancer rehabilitation fellowship are currently not recognized as a formal fellowship from the ABPM&R, and it's not accredited subspecialty of physiatry. I think they're working on creating that. So that means that every fellowship is different. There's no like basic guidelines that every fellowship have to follow to make sure that they have the competency to be a cancer rehabilitation physician. So there's a lot of kind of mix and match in that area, but they're working into hopefully developing that in the future. Right now, the last time I checked, I think this was last year, and there were 11 cancer rehabilitation fellowship programs. Some of them were very focused in inpatient rehabilitation, others were more outpatient rehabilitation. So technically, you don't need to have a fellowship to see patients with cancer you're training. However, getting more training definitely is a big benefit. So I'm all in creating cancer rehabilitation fellowship, because additional training is definitely take you to the next level. However, we cannot wait for that to happen. There's a lot of patients right now that need our help, and I always tend to kind of push. Right now, we need to step up and help this patient because we don't have enough time to wait to develop the programs. So what I tell students and residents is that try to complement your interests and practice. So if you're, for like me, I like sports medicine, musculoskeletal medicine. So that's kind of the type of cancer that I try to pursue and help, which is kind of head and neck, breast cancer, which is a lot of the musculoskeletal complaint kind of cancer. However, if you like brain injury, then cancer in the brain or spinal cord would be a great option that you can explore. If you like back pain and spine and spinal cord injury, you can maybe evaluate more that route. If you like amputation, there's a lot of sarcomas and amputation in cancer that you can help these patients, even in pediatrics and neuromuscular service. So I kind of bring this quote most of the time by Stuart Scott. And as a sports fan, we know that he was an anchor in ESPN. And in one of his last speech, he said that you beat cancer by how you live, why you live, and in the manner in which you live. So I feel this is very important. That is not just living and surviving. We have to make sure that the patients are having good quality of life and they are enjoying their life and they're back into society. In order to get into more details about specific of the things that we can see in the clinic, you can divide the different complication into the neurological complication, the musculoskeletal, the pain complications. Also, you can have some medical complications like heart issues, lung issues. You have then the treatment complication like chemotherapy and radiation treatment, and then the functional complications that also are very important. And also you can kind of go the route and see more of the inpatient side of cancer rehabilitation in the inpatient rehabilitation hospital, or like me, which is more focused in the outpatient rehabilitation that we see other type of patients usually with different kind of diagnosis. So I'm going to give you my example of what do I see in my clinic and how I can use the knowledge that I learned in PM&R and sports medicine to tend to help these patients. So a lot of the things that I see is kind of the musculoskeletal complications. And the big point that I always try to teach is that you have to identify the pain into three groups. You have to see if the pain is coming from the cancer itself, if the pain is coming from the cancer treatment, or is the problem coming from benign degenerative changes or trauma not related to the cancer diagnosis. And I always bring this patient that I saw at the beginning when I was learning by myself how to see these patients. This patient came to me from the breast center. It's a patient that was treated in another institution. She kind of got lost to follow up, didn't follow very well. She moved to Jacksonville, where we are. She was seen in the breast center. They were going to do some evaluation and check that out, but they complained about chest wall pain and kind of shoulder pain. So they sent her to my clinic to check her shoulder. When I see the patient, I notice as a PM&R doctor, they came with a 1-point cane, right? When patients have a cane, you kind of always kind of ask what's going on, since when you're using that. And she said that she has been using it for a couple of months because she's having this kind of severe pain around the hip region. And that always, with a patient with cancer, is very concerning. New pain, not clear etiology yet, severe pain that she has to use a cane. That kind of, I didn't like that approach. So I said, we need to do some x-rays and additional studies. So we start with the x-ray because it was very quick and easy to get. And I received a call from the radiologist that, hey, we need to do additional studies because there's signs of metastases all around the pelvis and in the shaft. So you can see here in the right shaft of the femur, you can see metastatic lesion, and all this acetabular wall, these are findings of metastases in the bone and cancer in the bone. So we kind of eventually did like a bone scan, and you can see all these kind of things that light up. She had like a metastasis to the spine and the pelvis. And then we did an MRI with a lot of metastasis in the acetabular region, pelvis, and in the shaft of the different femurs. So we called very quickly the oncologist and described what we found, and they brought the patient quickly and tried to start like aggressive treatment. So we kind of, in addition to help the patient with pain, we can also help diagnose different things that maybe our colleagues didn't think too much about because the patient didn't complain about it. I just noticed it because she came with a cane. However, the majority of the patient that I see is not this case. This was a special case. The majority of the patients that come to my clinic usually have pretty bread and butter stuff that we see in the PM&R clinic. So you can see here, I see adhesive capsulitis, rotator cuff dysfunction, some nerve issue, myofascial pain, tendinopathy, tenosynovitis, similar things that we see in the clinic. Yes, there are going to be some specific things for specific patients, like for example, in the breast cancer population, we have to think about lymphedema. We have to think about axillary web syndrome. We have to think about post-mastectomy pain syndrome, radiation fibrosis syndrome. So the idea is kind of complement your own knowledge and then expand the differential diagnosis by implementing these other diagnoses that you can learn and then start seeing it more in the clinic. So I'm going to give the example of what I tend to see a lot in my breast cancer clinic, which is a lot of chest wall pain and shoulder pain. So this is kind of my differential diagnosis, that when the patient complains about shoulder pain and they have breast cancer, this is kind of the things that I see. Do I think it's kind of shoulder arthritis? Is it frozen shoulder that is very commonly seen actually in breast cancer? Axillary web syndrome, post-breast surgery pain syndrome, all those other things. So we're going to go through my differentials right now. So one of the most common things that I see in my clinic with these patients is shoulder dysfunction or impingement syndrome. And why this happens? Because after you have breast surgery and radiation in that area, you develop like this shortening in the muscles in the anterior chest wall that usually is the pectoralis major and minor. And this kind of create kind of pulling the shoulder forward. And also most patients have weakness in their shoulder blade, which is the posterior shoulder muscles. And they kind of change the biomechanics of the shoulder, and they started having like decrease in the subacromial space. And that's how you get impingement when you do overhead activities. So we see this a lot in patients. So the treatment, as you know, is kind of good exercise program, strengthening, rehabilitation. Sometimes we can consider some pain control modalities like oral medications or corticosteroid injection, for example. Another thing that we find the differential diagnosis is axillary web syndrome, which is a condition that I have to learn because I never saw it before I started seeing this patient. And the other name is Cordy. And what happened is that the patient start developing after surgery this kind of cord in the arm that it can be seen in the shoulder, in the elbow, even going down into the hand. And sometimes you can see it even in the abdominal wall. And the idea is that it's a palpable cord in the subcutaneous region that we think is kind of a fibrotic or sclerotic lymphatic or venous system. Usually I feel it's more lymphatic, but some people believe it maybe it's a little bit of veins in that area, that they are not being used anymore, and they become fibrotic and sclerotic. And usually it's not painful, but when you try to move your arm, since you have that cord, you feel stuck, and it can be painful if you force it. So sometimes education to the patient that, hey, this is what's going on is very important, but also we can create like a treatment plan that usually is just therapy and rehabilitation, because what the therapy is going to do is kind of massage the cord until one day kind of pops and it breaks, and then the patient kind of regain range of motion without significant complications after. One of the most common things that I see actually is post-breast surgery pain syndrome. That other terms is post-mastectomy pain syndrome, post-lumpectomy pain syndrome. I'm trying to push now at the term of post-breast surgery pain syndrome because it's something that I can see with any kind of breast surgery. I see it with the mastectomy, lumpectomy, with reconstruction surgery. I have seen it with just implant of aesthetic surgeries in the breast. So it's something that it can happen. Nobody's sure why this happened, but the patient developed this kind of chronic pain in the chest wall here and sometimes in the proximal arm. That the way that I visualize it is that when they do the surgery, they have to cut through the lateral cutaneous branches of the intercostal nerve, which are these branches that you can see in the image. And those nerves then stay hypersensitive and hyperactive. So when you touch that area, it's very tender and it's very sensitive, and patients don't tolerate that very well. Sometimes it feels like a burning sensation, like a stabbing sensation, or neuropathic. Also, you can injure the intercostal brachial nerve, which it comes from the T2 intercostal nerve, and it kind of gives sensation to the proximal arm here. I don't see a lot of pain in this area. I see a lot of numbness, but usually not a lot of pain, but it can definitely cause pain in that area. I see it more in the chest wall than anywhere else. And the big problem with this is that 52% of movement diagnosed with this 4 years after surgery, after 12 years, they still have the same pain and the same problem. So this is something that when the patient develops this, usually the surgeon says, hey, it is what it is. I cannot offer you any option. This is just something that happened after surgery. But actually, there's a lot of options that we can offer this patient. And that's why the breast center liked me so much, because I started offering this option to the patient and they started to get better. So this is kind of my protocol of very basic things that we try to do. So I try to always start with rehabilitation, therapy, strengthening. Then we can consider some oral medication like a neurostabilizer like pregabalin or duloxetine. I feel that duloxetine works pretty well, so that's kind of my choice. But in my experience, patients with cancer are already tired of taking medication. They're taking so many medications that they're not very open to taking another one. So that's when we move to do some injections and intervention. And one of the most common one that I do is the serratus anterior plane block. So let's talk a little bit about that, because I do this injection relatively frequent. That basically what we do is we find it in the lateral chest wall, and we identify the serratus anterior, which is the muscle number B here, all this muscle. And we have the number A, which is the latissimus dorsi. So the idea is to put the injection in between the two muscles, which is the superficial serratus anterior plane block. That's the location that the nerve that I told you that it gets injured, they live in that space. So we're injecting that space to kind of block and calm down those nerves, and we put a little bit of steroid to see that help with the inflammation. You can always do it deep to the serratus, which is kind of rib and serratus, and that's another possibility. I tend to only do that when the patient have a lot of radiation in this area and they have a lot of scar tissue that I don't get a lot of separation between the planes, so I go deeper and put it there. There have done studies to compare the two, and the results are pretty similar. So I kind of try to do the superficial one, which is kind of farther away from the lungs and the pleura, which is something that we don't want to poke the lungs. So I tend to kind of stay in this level, but in some patients, we have to go a little bit deeper to see if that works a little bit better. So in this image, you can see the ribs, and you can see the intercostal muscles here, and then the pleura over here. So this is a video of the anatomy here, and you can see the thoracodorsal kind of artery going in view. So we see the rib, we see the serratus. This is going posterior to anterior. So we're seeing the serratus getting smaller because it's kind of joining into the ribs in the front of the chest. And you can see this diagram, and this is the two locations that we tend to kind of offer this injection. We just published an article actually a couple of weeks ago in Pain Practice, a journal of pain medicine, that we kind of describe different ways that we can offer injections around the plane blocks. I'm not going to get into all of them, but I welcome everybody to read the article if you want to learn these procedures, because we went into details of how to do different kind of injections around the chest wall to help with different kind of pain depending on where the patient presents. And it just got published actually in January, a couple of weeks ago. So hot out of the press. There we go. So this is an example of an injection. You can see the needle, and you can see the serratus and the latissimus on top, and you can see all this black area is the fluid. So injecting a lot of volume usually helps. So I tend to inject like 20 milliliters of fluid in that space because I wanted to spread significant area to see if that increased the chances of working. And this is another thing that I came up with, which is kind of a 5 tiers approach of treating post-breast surgery pain syndrome. And I put in tier 1 like the conservative treatment and rehabilitation options, and you said there is the physical therapy and the rehabilitation modalities, but also the conservative option like acupuncture, music therapy, hypnosis. There's a little bit of data, of course, not a lot of data, but it can be considered. Then tier 2, we can always discuss oral medication, and you can see it there. In tier 3, we have different injections options that we can consider for patients. In tier 4, in some patients, they will benefit from scar release, neuroma resection, or other kind of surgeries. Usually, I don't consider that option very frequently unless it's a specific patient with a specific problem. And then if nothing is helping, we need to evaluate the pain in more of a comprehensive and interdisciplinary manner, because a lot of patients, in addition to the pain, they have also fibromyalgia, and they have depression, and they have sleeping problems, and they're very, very active. And we can consider like a comprehensive chronic pain rehabilitation program that some institutions have to try to treat the whole body and help the patient. And we just wrote an article about describing all these modalities. It's currently being reviewed. So hopefully this year it's going to get published. If you want to get like a sneak peek, you can enter in PM&R Knowledge Now, post-mastectomy pain syndrome. We just updated the PM&R Knowledge Now last year, and we describe a little bit of our thoughts about the tier approach, but it's going to be more specific when we publish the article. Another common condition that I see in my practice is the aromatase inhibitor-associated musculoskeletal syndrome. One word. So basically, the aromatase inhibitors are a kind of medication that some patients with cancer receive after they kind of finish the treatment, because some cancer, especially in the breast, are hormone positive receptors. That means that estrogen can kind of give food to the cancer and increase the chances of recurrence of the cancer. So medication like this kind of decrease the level of estrogen, so that way the chances of the cancer coming back is less and the patient receives benefits. But you can think that if you decrease the hormone levels in your body, you start developing symptoms. So some of the symptoms that we find is kind of joint stiffness, joint pain, arthralgia, bone pain, sleeping problems, mood changes. For some reason, this also kind of develop trigger fingers and carpal tunnel syndrome. I see a lot of patients with this medication that develop this from nowhere, and they have 3 trigger finger in one hand and 4 in the other hand at the same time, so they're going crazy. Treatment is exercise is very important to mitigate the side effects. It helps with fatigue and it helps with a bunch of things, with neuropathy and all those things. Therapy, rehabilitation, sometimes injection, acupuncture can be considered. Radiation fibrosis syndrome is another specific diagnosis that we see after radiation that basically is an accumulation of thrombin in both the intra and extravascular compartments that kind of affects the skin, the muscle, the ligament, the tendon, nerve, everything. We used to see it more when the radiation field was bigger 20, 30, 40 years ago. But now, since the radiation field has gotten smaller, it's not that common, but I still see it in the practice and in my clinic, and it can be very morbid. After it's already kind of stiff and there's fibrosis in there, there's not a lot that we can do. So the treatment is basically early physical and occupational therapy to promote range of motion and avoid kind of this kind of contraction in that area. So it's a very, very difficult condition to treat once you already have developed it. It's just some example of some stiffness in the trap over here in this guy in this book. Another common issue is the spinal accessory nerve palsy after head and neck cancers. As you know, the spinal accessory nerve comes from the cranial nerve and travel down to the neck. So when you do dissection and surgery in this area, you can injure the nerve. Most of the time, it's just like a mild injury, neuropraxia from maybe the compression during surgery, but sometimes it's a transection of the nerve. And electrodiagnostic study can help us determine the severity. If there's no activation at all, it can be more concerning. Usually rehabilitation is one of the biggest options, or TUSIs, or acupuncture. But I find that education also important, because I see patients in my clinic that they don't understand why their shoulder hurt. And when you check, they have winging and all these things in the shoulder blade, and you just explain what happened, and they understand what's going on, and they calm down a little bit more because, okay, and now I know what's going on. Another possible complication for head and neck cancer is kind of trismus. Trismus is basically the impairment of opening your mouth. So think about it. If you have difficulty opening your mouth, you have difficulty chewing, swallowing, you have difficulty brushing your teeth for hygiene, you can decrease weight because you cannot eat very well. Your pulmonary function can be affected also. So this comes in very, very challenging also to treat, that we help with speech therapy and some physical therapy to kind of treat. And we see that after radiation, usually in the head and neck. There's different devices that you can try to kind of open the mouth, physical therapy, speech therapy, jaw opening devices. Sometimes we can have to consider like Botox or botulinum toxin in the muscles here in the mouth. So this can be very, very challenging. Another diagnosis that I see a lot is cancer-related fatigue. 60 to 90% of patients with cancer have some level of fatigue. They feel tired all the time. Even when they sleep, they still feel tired. They feel exhausted by the end of the day. And this is affecting their quality of life and functionality. So it's something that we can definitely address. The way that we can address it, at first, I tend to order some basic labs, because there are other things that can cause fatigue, like low hemoglobin or thyroid issues or deficiency in vitamins. So I tend to do like a basic kind of workup to make sure that I'm not missing, because I have a few patients that they already have thyroid problems. They were taking their normal dose of the medication, but now their levels are, the TSH was super high, so that dose was not enough, and they needed to optimize that dose. So that helped that patient. So we always can pick up something there, but most of the time it's normal. So we educate, we counsel, and then we talk about exercise, basically. Exercise is the main treatment for this. There's some medication like Ritalin and things like that that can be considered, but I rarely use them. I feel that exercise is our best friend, and patients tend to get better after a couple of months of starting an exercise routine. Then we cannot never forget the cognitive and psychological kind of health of patients for any condition, but especially with cancer, because they have been diagnosed with a serious diagnosis. They usually have gone through difficult treatment options. This has affected their job, it has affected their family. So we have to make sure that we always ask questions about their emotion and their mental health. And another thing that I learned also is that we need to also ask to see how are the emotions of their significant others or family members. I have one patient that she had like stage 4 metastatic cancer, and the outcomes probably were not going to be great. However, she was dealing with it pretty well. However, I asked the question to the husband how he was doing with all this process, and he started crying like in 2 seconds. So actually, the patient didn't know the husband was kind of struggling with all this process. So it's important also to kind of evaluate this possibility, because I have found that if we ask the right questions, we can find something out that we can help. Now let's kind of transition a little bit more of the procedures. I wanted to make sure that we have enough time, so we're at the end of the presentation probably soon, if I'm not mistaken. Maybe not. We're still talking about exercise, but let's talk about EMGs. This can be very important because, like I said, a lot of peripheral neuropathies, a lot of nerve injuries can happen for treatment. So electrodiagnostic study can be very helpful. So if you like this procedure, it's something that you can try to pursue. The oncology team to maybe consider you to kind of evaluate some of these complications. And this is just a short list of things that you can find from patients with cancer, neuropathies, plexopathies, neuromuscular conditions, mononeuropathies like we discussed with the carpal tunnel and the spinal accessory nerve. So definitely there's a big role of possible electrodiagnosis with this population. Also ultrasound. I'm a sports doctor, so I use a lot of ultrasound in my practice, but I also use it with my patient with cancer. Usually I don't use it for diagnostics, so if you have a mass, I'm not going to put the ultrasound and kind of describe the mass. I will leave that to the radiologist. But definitely we can use it for like musculoskeletal problems and maybe guide procedures. For example, on the left top, we can see a nerve hydrodissection of the median nerve. So you can see the median nerve, and on top, there's one of my needles, and we can hydrodissect for carpal tunnel syndrome. Like I said, we see that a lot in some patients. In patients with frozen shoulder, we can do a high volume hydrodistension of the shoulder capsule. And you can see here the humeral head and the glenoid and the infraspinatus muscle on top. And you can see the needle over here with this expansion of that capsule with the fluid. And that has been shown that can be very helpful for patients with frozen shoulder. For trigger finger, you can see here the flexor tendons, and the A1 pulley is right here. So I just put in the needle deep to the A1 pulley, and you can see the tendon sheath filling with fluid, and that can help with trigger finger. And then we already talked about the serratus anterior plane block, and this is a video of the procedure in terms of injecting fluid. So ultrasound has been very helpful for me in my practice. And now let's go to talk about one of my favorite topics, which is exercising cancer, and what is the role of doing a good exercise prescription for this patient. Sometimes they send me patients just to talk about exercise. So I spend 30, 40 minutes talking about how to start an exercise routine. And I'm going to tell you why, because it becomes very important. One of the reasons that I convinced the oncologist to send patients to me to be more specific with their exercise routine is because if you tell patients to exercise, they're not going to do it. We have found that 70% of the patients with cancer do not meet the aerobic exercise guidelines, and 90% do not meet the resistive exercise guidelines. And the way that I divide the benefits of exercise is there's evidence that it can help with the prevention or decrease the risk of developing cancer. There's evidence of mitigating and decreasing the side effects during treatment. And there's evidence about survivorship after you finish treatment. So let's get into that approach. So in terms of preventing or decreasing the risk of developing cancer, as you know, exercise can decrease the risk of multiple conditions like cardiovascular problems, diabetes, and all these other conditions. But also there's evidence that it can decrease the risk of developing cancer. And the most recent data that it was this systematic review that was published in 2019, they showed that they have strong evidence for colon cancer, breast cancer, kidney, bladder, stomach, and adenocarcinoma of the esophageal. Moderate evidence for lungs, and then limited evidence for head and neck and all these other cancers. Limited evidence do not mean that it doesn't work. It's just that it has not been studied enough to find a strong correlation. So what happened is that every 5-10 years that they update this systematic review of the American College of Sports Medicine, they start moving more things toward the strong evidence. And depending on the cancer, the evidence is between 10 to 24%. So that's a significant amount of percentage just by increasing your level of exercise. So I encourage everybody to start exercising, because definitely it decreases the chances of getting cancer. And there's a role for possible prehabilitation. After you get cancer, sometimes we have to wait for surgery. We cannot do surgery very quickly. And that's a good opportunity to maybe we can increase your strength to help you tolerate the future treatment that is coming up. For example, if you're going to have a bone marrow transplant, and usually that is not from one day to another, it takes like labs and evaluation and studies. In the meantime, we can do like a good strengthening program. So when you do the bone marrow transplant, which is usually takes a big toll to your body, you're a little bit stronger, so you can tolerate a little bit better. So there's a big role for prehab in this case. And then exercise during treatment. Number one, we know it's safe and beneficial. And the reason that I say that is because back in the day, every patient with cancer, every doctor tell the patient, no, you need to rest. You need to conserve your energy. You cannot exercise. And they treat the patient like crystal, like you're going to break. I'm sorry, you have cancer. Let's take it easy. Let me help you out. Actually, we have found that it's more beneficial to do the contrary. We want the patient to exercise because we have found that actually they can tolerate the treatment better, the neuropathy can decrease, the fatigue can decrease, and they can tolerate the treatment, which is very important. So every patient needs to be exercising as tolerated with the guidance of a doctor. And this is just a short list of different benefits that you can find from exercising during treatment. Decrease neuropathy, nausea, heart problems, osteoporosis. It can improve your depression. It can improve sleeping problems. So there's a bunch of benefits. And I'm very glad to see recently that in the oncology guidelines and oncology journals and oncology societies, they're promoting exercise as a recommendation. They say in the latest guidelines that every oncologist need to provide aerobic and resistant exercise recommendation to their patient because it has been shown that it's safe and beneficial. Okay, so what my oncology do is that they send it to me and then I do it. But hey, we take it. That's a win. Patient get better, they exercise more, and they understand the benefits, and they improve significantly. And this is kind of the big thing that I tell patients to try to convince them also, is that there's a lot of benefits after you finish treatment for exercise. For example, for breast cancer, these studies are for breast cancer. By increasing your level of activity, you can decrease the risk of developing cancer, of recurrence of the cancer by 24%. You can reduce the mortality of the cancer by 50%. And if you do exercise in a high intensity, it's a newer study that came out recently, you can decrease the bone metastasis to 72%. So when I tell this number to patients, I tend to convince them like, okay, I need to exercise because I'm going to continue to fight cancer with an exercise routine. And the other big a mistake that some doctors do is that you tell the patient to exercise and that's it. If you don't give specifics, the patient are not going to do it. It's like if you're giving like a prescription for a pill to the patient and you don't tell them how to take it. It's once a day, twice a day, once a week. So you have to kind of be specific in your recommendation for the patient to follow it, okay? So what are the goals? The goals is that the patient need to achieve at least moderate intensity exercise of 150 minutes per week or vigorous intensity exercise of 75 minutes per week, which is the same recommendation that everybody needs to be doing. And then we complement that by incorporating a 2 or 3 times a week of strengthening. And that would be a great program. However, if the patient is not used to exercising, I tend to start with a lower level of exercise routine. So I tend to tell them, let's start exercising 20 minutes, 3 times a week, which is usually very reasonable. Most patients can do it. And I just wanted to start getting in this routine that they will do it, and eventually we're going to optimize it. And to optimize it, as you know, I'm not going to get into much detail, but we can optimize the frequency, the duration, or the intensity of the exercise, okay? So that's something that I spend significant amount of time explaining to the patient how to optimize each one of those. And I even give the patient like a table that they can kind of, it's like a journal that they can write per week, their duration, their intensity, their frequency. So that can keep them accountable and they know what's going on with their exercise routine. In terms of intensity, we know that anything is better than nothing. So even mild intensity helps. But we should achieve to try to incorporate more moderate to vigorous intensity. Most patients tolerate more moderate, but I try to kind of push a little bit more for moderate. And these are tips that I give patients to keep them moving. Pick an activity that you enjoy. If you like walking, let's walk. If you like swimming, let's swim. If you like cycling, let's do cycle. You should add also what I call the physical activity snacks, okay? These are things like walking the dog and walk the dog a little bit further, a little bit longer. That will help. Park, instead of the parking in front of the store, park in the last parking. So it makes you walk more towards the store or the building. You should choose a time to be active each day at the same time, because that will create this routine. So you wake up, you exercise, or you finish work and then you exercise. That will help you kind of create this routine. Keep track of your exercise. Like I said, the diary helps. And then also you can team up and be active with a friend, which also is very helpful. So patients sometimes ask me, when is the best time to start? And it doesn't matter. The time is now. The best timing is today. So I tell patients, let's start today or tomorrow morning. And that's the best time to exercise. It doesn't matter if it's before the treatment, after treatment, or during treatment. There's some precautions that I kind of is in my mind, but most patients, they're pretty good and we don't have to follow them. These are more patients that are admitted and it's more kind of serious systemic cancers. When I see them in the outpatient, usually they're pretty stable. But we can always follow the hemoglobin, the white blood cells, because if they are immunocompromised, maybe exercising at the gym or a public place is not a good idea. If they have a low platelet count, we have to be careful with bleeding. So doing like exercises that we avoid any falls or trauma. If they're vomiting or have a lot of diarrhea, we need to follow their sodium and potassium. If they have a history of cardiopulmonary problems or they're taking a chemotherapy that affects their heart or lungs, we need to monitor them a little bit closer. There's always a fracture risk, especially if you have a metastasis to the bone. If you have an ostomy, then maybe swimming is not a great idea. If you have severe pain for some reason, we need to manage the pain for you to tolerate the exercise. If you receive radiation and your skin is irritated, maybe exercising outside is not a good idea, or maybe cover yourself with a longer sleeve. If you have neuropathy, you may have balance problems, so you are at risk of falling. And if you also are taking blood thinners or have a risk of bleeding, we have to be careful. So just to finish and make sure that we have enough time for questions, many of these problems are issues that we learn in the residency as a normal PM&R complaints. You just have to learn some specific things that may be specific for the diagnosis, but that will come with time and experience. It would be a learning process. Like I said, I just learned by myself seeing these patients. It wasn't that hard. I just read a few paper articles, expand your differentials, see a few conference, and then you get very good. And a lot of the time I talk about exercise, which is fun, just talking about exercise and try to convince patients to exercise, which is not that bad. So I will finish my presentation with this quote from Jimmy Valvano. He was a college basketball coach that also died of cancer. And he has a very famous speech that you can look it up on YouTube. That he said, cancer can take away all my physical abilities. It cannot touch my mind. It cannot touch my heart, and it cannot touch my soul. So I kind of encourage everybody to be open to seeing patients with cancer during their training, or if you're already finished training and during your practice, because I feel that it's very rewarding and the patient really appreciate it. I think that's it.
Thank you so much, Dr. Rosario. Does anybody have any questions or comments?
I don't mind starting. Thanks for the presentation. That was awesome. I learned a lot and things I've never really thought about and seen before, which is cool. I'm wondering, like, as a initial sports medicine physiatrist, how much is cancer rehab like taking up in your weekly kind of bandwidth?
So right now, I would say that it's like 25%. I work 4 days a week, probably maybe 25%. So probably we'll say 1 day or a half day a week is usually patient with cancer. And again, you can do as much. Like I have many hats because I do sports, I do orthobiologics, I do rehab medicine, I do procedures, I do cancer. So there's a lot of more opportunity for me to explore and try to help more patients with cancer, but I don't have the time because my clinic is already booked with all these other things. So it depends how much you want to see or how little you want to see and try to implement that in your practice.
Awesome, thank you. I'm wondering because you talk about this huge need, so I'm thinking like when you start recruiting from the oncologists, they're gonna overload you and you're gonna be booked up for months.
So you will think that that's the case, right? But I have found that it's more challenging to get them to send you patients than you think, because it makes sense, right? Everything that I said is like, oh wow, it kind of makes perfect sense. I have met every single probably department here that treat cancer, and the breast center has been the one that's very open to it. And so it has been challenging to kind of convince oncologists to start like a referral pattern. In the breast cancer, it was challenging at the beginning. I just got one doctor that started sending me a lot, and then their patient would start to get better. And then she started saying that to their other doctors, and they're like, what? And they started now sending, and that's the idea of finding maybe a champion within the department that he will send you a lot, and then everybody will follow eventually.
Dr. Rosario, what is your approach when you go and talk to oncologists? Like something like this presentation, I think would be so helpful for oncologists, but obviously they also don't have the time. So what is your approach when you talk to them about it?
So I tend to try to find academic didactics. So if they're teaching their fellow or they have a grand round of things like that, because they're always looking for somebody to speak in those things. So I kind of volunteer. I'm like, hey, I would like to meet and talk a little bit about it. Maybe I can give you a presentation. And then when I kind of present to them, I tell them, I'm here to help you. I'm going to help you help your patients. You cannot come out with like, you should be referring, you should be sending me patients. No, you're going to say, how many of these things do you see in your clinic? Do you see frozen shoulder? Do you know how to treat that? No. So those are patients that you can send to me, and then I can help you take care of that because you're very busy thinking which chemotherapy is the best, what lab you're going to order the rest. They're very busy trying to treat the thing that they're good at it. And I tell them, hey, I will take that out of your hand send it to me. I have enough time to talk about all these things, and then we take care of that problem. And usually that's where they feel more receptive of like sending patients to the clinic. And usually also nurse practitioners and the physician assistant or the residents, they tend to kind of refer more at the beginning than the doctors. So just talking to the nursing team, I think that helps.
Great, thank you. Does anybody else have any questions for Dr. Rosario?
Perfect.
A little more specific question about kind of like post breast surgery pain syndrome. I feel like that's something I've heard of a lot, just kind of going through medical school. And like you said, it seems like a lot of people just say like this is your new normal and kind of deal with it. So it seems like a huge need. And I'm wondering what like if you know percentage of patients will get better with conservative treatment with either therapies and exercise versus adding up pharmacologically, and like what percentage of people are advancing to needing these procedures, and then how do those people do?
So a lot of my patients, we start with the rehab and strengthening, but most of them are not 100% better, so they want to consider other options. So they feel better, they feel stronger, the symptoms are a little bit better with rehab and strengthening, but they're not 100%. So I tend to offer this injection in those patients. The last time I checked from my own data that I got at the beginning is that 70% of my patients were very happy with the results. And the other 30% didn't improve. But what I found out is that those patients also had like fibromyalgia, they had depression. So they have other kind of comorbidities that I think may have interfered with their recovery. And those are the patients that then I consider this kind of multidisciplinary approach of treating their pain by improving their sleeping patterns, improving their mood, improving the level of activity, and then they tend to get better. All right. We're done.
Yes,
So,
thank you so
all right.
much. Not only was this informational, educational, but it's also very inspiring to see how such an advocate you are for your patients. So thank you very much.
I really appreciate the invitation. I always enjoy kind of talking to students and try to get them like involved a little bit in what I do. And I'm excited about different options that sometimes you don't hear too much about, but learning them kind of maybe explore it in the residency in the future.
Definitely. Thank you. And it definitely your enthusiasm for this definitely shows. And so that I mean, for me, that helps me be more interested in it as well. It's very exciting.
Yeah.
All right, everybody, thank you for coming and have a great rest of your night.
Thank you.
Thank you so much.